30 minutes is not enough time to cover what I need to cover when it comes to headache or pain issues. So I got a very brief talk yesterday, and then this one is also brief, unfortunately. But I want to just cover a couple topics I think that are pertinent to the folks who have either Chiari or Syringomyelia. So first of all, just in general, and I know Steve Lieber's going to talk later too, but what is migraine? And it's very, simple to say what it is. It's much more complex to really understand it in its true intensity. But migraine is really a chronic disorder that has episodic attacks. A lot of funky things happen during migraine. There's this oversensitivity of the lining of the brain and this oversensitivity of everything that controls sensory input into our bodies, which means that things that are not supposed to be uncomfortable, light, sound, smell, taste, my in-laws, all that stuff becomes more intense, becomes more irritable to the nervous system and starts bringing out trouble. And some people are just more prone to trigger this reflex than other people are. Can I see anyone in the audience who's never had a migraine before in their lifetime? I feel there's a couple people. I'm going to pick on you, sir. So have you or anyone you know ever had an alcohol-induced headache that would be like a hangover? Okay, yeah. I'll pick on you some more then, since you're admitting to that. It gets only worse from here, let me promise you. So if someone has an alcohol-induced headache that's the next day, tell me, are they prone to wear sunglasses or want the lights down low? Sure. Absolutely. What if you were to say hello to them or good morning in a really loud voice? What happens? It wouldn't be happening, right? You might get smacked back, And then the other thing is, there may be like a throbbing headache with this. And what it turns out to be is that if someone has a hangover, and I did graduate from Michigan State University, we're experts in this. But if someone has a hangover, that is an alcohol-induced migraine. So for people who said, I've never in the world have migraine before, I say, well, listen, have you ever had a hangover? Oh, I sure have. And suddenly they have instant ideas of what you're talking about because that's an alcohol-induced migraine. And some of their most effective treatments for migraine actually work on hangover headache. So it's kind of cool. And if you look at what happens with this, if someone has a low-grade headache, something we call a mild tension headache, just mild, moderate headache, that's squeezing pressure, that's where the nervous system gets just a little bit revved up, and then it calms down by itself. Some people don't have to treat that at all. Some people just take like ibuprofen, it gets better. But if the nervous system gets more and more revved up, so it gets a little bit more intense, and then instead of being able to reduce itself, it gets even more inflamed. Let's say you've got to work extra at your job, or let's say your child is starting to watch The Wiggles for the 4th time over, and that can irritate the nervous system even worse. That can actually go even further into migraine, where you start triggering so much overactivity of your body that you get light and sound sensitivity, nausea, or a worsened headache. And then let's say you either it gets better on its own, or you use some treatments for it and it calms down and you're all better. Well, let's say that same episode occurs again. You had to work late. Your kids are fighting in the back seat. That happened to me yesterday. And then your in-laws come visit. Suddenly you can irritate that so much your headache gets stuck, and people get stuck in this persistent overactive nervous system where their body is overrepresenting all incoming sensory stimulus. So for some people that's touch, some people that's light, some people that's sound, and that really represents a persistent daily headache for some people. So how does this relate to folks who've got Chiari malformation or Syringomyelia? Let's talk a bit about that. Here's some unique things about the anatomy, and I mentioned this briefly yesterday too, but if you look at the lining of the brain or the large draining vessels of the brain or some of the posterior fossa structures, that's where the cerebellum lives, those are all relatively pain-sensitive areas of the body, and those can all bring out or irritate headache or pain for people. If you look at the cerebrospinal fluid specifically, that's got a certain amount that has to clear the body every single day. We make about 500 cc's of fluid per day. That number is debatable, give or take. The normal amount of volume in a normal adult's brain and spinal canal of cerebrospinal fluid is about 210 cc's of fluid, which means if we make 500 a day, it's 210 total volume. We're essentially processing and repleting our cerebrospinal fluid 2 or 3 times a day. If someone has high pressure or if someone squeezes off a vein, you can't get that blood or you can't get the cerebrospinal fluid out of your body, and then you get this buildup of pressure and headache. And that becomes a big problem for some people. Runs into all kinds of issues with irritating those pain-sensitive structures. And this is what some of the bad things that can happen. Here I've got a picture of someone who's got a block of their sagittal sinus, and for those who aren't like Dr. Buparaj, who can look at these things and pick them out immediately, this thing right here is a dye study where they've injected someone with dye material, and they're looking at the blood vessels specifically. So they've tried to make all the other things besides the blood vessels go away, and in this case, everything besides veins go away. And you can see you've got this kind of vein that goes all the way down the top of the head, and it narrows down here, and it narrows down on these sides too. And that's because there's a blood clot there, and that causes an abrupt onset of pressure and daily headache and can give people trouble. And if there's any issues with the collection system or the drainage system for this, you can get really persistent headache. Some of the other things that bring up pressure to be aware of: if you're already prone to have high pressure, you're already prone to have a shunt in place, you're already prone to have a structural issue that can cause high pressure, these medications can worsen it. So it's not uncommon. We have folks who are in their teenage years, they've got some acne issues. They go see their helpful dermatologist, get placed on medications such as isotretinoin, or get put on medications like doxycycline, all reasonable treatments for acne. And suddenly their headache is much more intense. And that can be because their pressure's been built up, because a side effect of some of those medications for some people is increased pressure. So you got to be aware of those things. There's some hormone therapies that are also known to do this, especially women who are treated for breast cancer. That medication used most commonly for that can cause high pressure for some people. I'm going to skip this for a second. Obesity. Obesity is a big deal. So if someone has high pressure and they've been shunted or whatever else, we still want them to lose weight. This slide's scary. One of the scariest I'll ever show you guys. Look at that picture of the United States. Don't worry, Michigan's well represented in this picture. That shows the obesity trend from 1995 to 2010. My favorite part about this slide is they chose yellow and red to represent the fat pictures on the right side. That sounds like McDonald's to me. So what are the signs if someone has too much of pressure? And I got this picture here. First of all, don't ever join the Korean army, because I don't want that job, right? So he's holding a target. I really hope his partners are good at shooting. And the reason why I show this is because there's not just one symptom. There's not a bullseye, aha, that's exactly what high pressure is. High pressure can be a bunch of different things. But we know that headache's very common if someone has high pressure. But some people get things called transient visual obscuration if they have too much pressure in their head. What that represents isn't that they go blind for 10 hours. It means that they lose sight just for a second or two. Almost like whoop, it went out and it comes right back again. Transient visual obscuration. And that's not normal. You're not supposed to lose vision for a second or two and have it come back. What we think happens there is that there's pressure changes in the back of the eyeball that actually snuffs out some of the nerve fiber for a brief second or two, and then it comes right back again. Some people get this thing called pulse synchronous tinnitus, and that's a fancy list of words to represent a ringing of the ears that goes along with your heart rate. So, you know, whoosh, 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 something like that. And people get pain around the eyeball. You can get pain with eye movement, and those are all signs of intracranial hypertension. If you look at people with brain MRIs, you can see signs of hypertension because the pituitary gland gets smaller. And it's not that it shrinks, it actually gets squished. It gets squished up against the bone where the pituitary gland lives. That's what that red arrow is showing. And these people, if they have intracranial hypertension, the cutoff is greater than 25 centimeters of fluid. That's when they do a spinal tap and look at pressure. The deal with this is if someone's had shunts, if someone's had posterior fossa surgery, those numbers are nebulous, because now we've got a system that isn't operating the way that it was originally studied or intended, and those numbers are harder to interpret. So who's ever been to the eye doctor and had, or just your regular physician, have them look in the back of your eyes? Anyone done that before? Anyone have any clue what they're looking for back there? What's that? Well, that's part of it. Yeah, retinal degeneration. There's other answers I'm looking for too. I'm hunting for things. Pressure, yeah, pressure is what I'm looking for. So this is the normal back of the eye. Let me show you what it looks like. This is a video. Not my personal video, it's not the best, but it shows what I'm looking for. I want you to look right here. See this vein right here, this kind of red thing? This is the back of the eye, and see how that thing's pulsing? Can you guys see that? That's great. You know, that's venous pulsations. Those are spontaneous, meaning if you look at 2/3 of normal human beings in the back of their eye, you're going to see this area here, which represents where the nerve connects to the back of the eye. Then you're going to see these blood vessels coming out from where the nerve connects to the eye. And if someone has normal pressure, 2/3 of the normal folks out there have a normal pulse back there. That's good to see. If you don't have a pulse, it doesn't mean anything, except if you're concerned about intracranial hypertension, that means you need to be a bit more concerned and look into things a bit further. This is a normal eye. So this is normal venous pulsations. The back of that looks healthy and normal. That's good. Let me show you some things that are not good. So this is someone who's got intracranial hypertension. So if you compare it to this picture, where you've got a nice clear circle here, you can see the blood vessels coming out real nice. In this picture, you can see that there's no clear circle anymore. This is all swollen. And these blood vessels, instead of seeing nice clear blood vessels, they're all murky. You can't quite make them out. This is someone who's got high pressure, and that's what they're looking for mostly when they look in the back of your eyes. Some eye physicians are excellent at looking for all kinds of other problems in the eyes. Most neurologists, this is their main question. First question is there any swelling in the back of the eye? Do you see venous pulsations? If you see venous pulsations, your chance of having high pressure is almost zero, not exactly zero, but almost zero. If you don't see the venous pulsations, that doesn't mean you're concerned, so it's a way to exclude high pressure, but not a way to include it. But if you see stuff like this, now you're concerned. I got some progression pictures here too. So in the first picture, you've got someone who's got pretty normal eye findings. Then you got some subtle swelling here, and that's what's like, it's a bit of swelling, but you can still make out a circle there, so you'll see the blood vessels and things. Here you got some moderate swelling. It's enough to make that cup and disc issue raise up some, and then you've got complete swelling here. And that's a problem. You don't want to do that. It can cause visual loss. So if you've ever been to an eye doctor where they put your face into one of those bowls, you got a buzz when the lights come from the sides. That's what they're looking for, and this maps out where you can't see. And people with too high of pressure lose vision on the side of their eyes. So that this is showing that someone sees completely fine straight ahead, but on each side of where their eyes are looking, they can't see on the sides of it, and that's a problem. So should you be treated for headache, right? This is a question for everybody. I've got some patients who come and say, you know what, I was told I'm going to have headache all the time. I've got a Chiari issue, it's been surgerized, and now I'm just going to have a headache, and that's just how it's going to be. Well, there are treatments out there, things to know about, and so to not get treated is kind of like what this guy is doing, you know, and he says might be the stupidest thing I've ever done. Check out what he does. Don't do this at home. What's he missing here? I know, right? You think he'd be concerned? Check this out. Nope, not really. So he's just chilling out there. And I'm going to stop it there because I'm going to leave it as a cliffhanger. Who knows what happens to this guy? I do, because I watch YouTube. But yeah, so it's really dumb. I have people who say I'm not going to get treated because I'm told I'm going to have daily headache. And that, you know, it may not be that you may not always have excellent control of headache, but it might be that there's things that can be very helpful for it. So let's take a look at a few things you can do. First thing, if someone has a high pressure issue, there's a few medications that focus specifically on high pressure issues. Most famous one out there is called acetazolamide, also known as Diamox. Anyone heard of this medicine before? Anyone been placed on this medicine before? Cool. So what they were trying to do with this medication isn't its intended purpose when it was first designed in the 60s or 70s, which was to cause your body to pee more. It was a diuretic. What they're really trying to do is a lower pressure of the cerebrospinal fluid. So this medication can reduce production of cerebrospinal fluid by up to 50% in some people. For those who have raised their hand being on the medication, who noticed having a taste change when you're on this medication? Yeah, some people did. And what's the number one thing people can't taste while we're on this medicine? So soda pop is what I'm looking for. It makes pop taste flat. A quick anecdote on that. A patient of mine was on a medicine similar to this one, and he went into a bar. It sounds like a joke, but it's not. And he ordered a beer, and he's a local, well-known guy at this bar, and he got into an argument with the bartender. This beer's flat. It's flat. I tell you, it's flat. Because that's what this medicine does. It takes away taste sensation for fizzy pop and for beer. And the bartender's like, it's not flat. He says, it's flat. And he got in such an argument, he was asked to leave in not a polite way. Goes to the bar down the street, says, darn it, I'm so mad I want a beer. This guy probably had a problem. And the beer came, and guess what? It was flat there too. So he got in an argument with that guy too. This guy's hot in the collar. And it wasn't until he left and realized it was probably the medication he was on that he made that association. So as far as he tells me, he's welcome back at his first bar, but I don't really know the real answer to that. But anyway, these medications can be really effective for lowering pressure for people. In general, pretty well tolerated. So outside of funny taste, people get tingling of the hands and feet. That's pretty common. And that's a side effect that can be treated by using electrolytes, either sports waters, Gatorade, or whatever else you prefer to drink. That'll take it away. Or eating lots of bananas will, because what you do is you flood your body with electrolytes, and that makes that medication-induced sensitivity of the hands and feet go away. I had a question yesterday about using SNRI class medications. The ones that are famous in that group is Cymbalta. Also in that group is something called Effexor, also something called Prestique, and then also something called Savella. And these medications are relatively effective. All of those medications I mentioned are FDA approved for treatments for fibromyalgia, which is a centralized pain syndrome, and I'll talk about that in a bit. But duloxetine is the one we use the most in our clinic. That one's known as Cymbalta. Cymbalta was made after the medication that was called Pamela that you guys remembered from yesterday. Pamelor was bent and twisted. And what they did is they amplified norepinephrine, which is a way of treating pain as well as reducing some of the nervous system overactivity. And they tried to amplify norepinephrine's response from Pamelor. And when they did that, they came up with this medication called Cymbalta. We typically dose this higher than what it's FDA approved for depression. So the dosing for depression goes up to 60 milligrams a day. When they studied this medicine, it didn't mean it was unsafe at higher doses. It didn't mean it didn't show any benefit for depression. For pain control, it typically goes to 120 milligrams a day. So when we meet people who are on this medication and are not getting response at their lower doses, we typically increase it. So the next thing is some medicines out there that are used to treat headaches sometimes can actually irritate headache. This, if you can't read that, it says, "Have a seat, Kermit." What I'm about to tell you might come as a big shock. And so if someone has just a moderate intensity headache and they walk into CVS or Target or wherever they like to shop, what's the first thing they're going to use or try to purchase? I heard someone say it. Well, Excedrin, right? Excedrin. Who knows what's in Excedrin? Anybody? Awesome. You guys are certainly more with it than most of the folks I talk to. So anyone, all right, this is for extra credit. How much milligrams of caffeine? 65. Shazam. 65 is correct. All right. So how much, all right, we'll do this then. How much caffeine is in a regular Starbucks-sized coffee? About anywhere between 150, maybe 200 milligrams, so quite a lot, right? But Excedrin migraine. So if someone goes and uses Excedrin migraine, it's effective, right? Caffeine is effective for headache. Acetaminophen can be effective for headache. When you combine them, it can work pretty well for headache. But the challenge is if you start overusing that medication, it can become problematic. If someone says, I used Excedrin migraine and it was working effective, but it stopped working, and they walk back into the same red dot boutique that we call Target and ask for another treatment, what's the next thing they're going to reach for? Well, Excedrin extra strength, right? So what's the difference between Excedrin migraine and Excedrin extra strength? The questions get harder from here. More Tylenol, more caffeine. You're all wrong. This is a trick question. Nothing. There's two answers I'd accept for this answer. The first one is it's in a different colored box. That's correct. Green and white versus red. Second one is cost. So if you don't believe me, I just checked this out a couple months ago at Target, but Target charges us 65 cents more for the Excedrin extra strength compared to Excedrin migraine. If you read the fine print in the back, it's the same exact ingredients made in the same factory, probably same conveyor belt. One gets put into a red and green box, other one gets put into a dark red box. Must be more expensive ink for the green. That's the only thing I can come up with. But here's the thing. If someone has episodic headache and they start overusing these medicines, it causes an escalation of headache. So people start getting severe headache, but then they also get this low-grade, persistent, modest intensity headache. And so if you feel like this pressure squeezing sensation in the sinus cavities, and it's going to be there on most days, and you walk back into the pharmacy, what's next? Excedrin tension headache, right? And so people start using these medications to kind of hobble through the day, and these can irritate the nervous system. They can bring out more headache for people. And if you start activating more and more migraine symptoms because of persistent headache, that kind of growing chart I showed you earlier, you start picking up other features of migraine, which means eyeball watering, nasal stuffiness, facial fullness. And then, of course, don't stop there, Excedrin sinus headache. And I've got some people who mix and match these thinking they're being effective for a headache, and the most tablets per day I've ever had someone take, documented, not just told me, but documented, is 24 tablets a day of Excedrin. So you were correct about 65 milligrams of caffeine. Let's multiply that by 20, carry the one. That's going to be, some 2,000 grams of caffeine. That's equivalent to taking about 10, 12 cups of Starbucks per day. So what happens to sleep quality with that? Yeah, so people start adding more things for that too. Bam, Excedrin PM. Okay, now for the smart people in the audience, what's an Excedrin PM? Benadryl, diphenhydramine. And what does that do to sleep quality? I'll give you the hint. It lowers your quality of sleep, makes you feel drowsy, but your quality of sleep's less for most people. What that means is you shut your eyes, you feel like you slept for 8, 10 hours, you wake up and say, I don't feel like I slept at all. I feel kind of like garbage. And if that happens, and we know if you take conditioned athletes, varsity letter winners at a college situation, and you sleep deprive them. These are people without headache symptoms, without muscle pain symptoms. The number one symptom they get, if you sleep deprive them, meaning they can rest whenever they want, but every time they go into slow wave, high quality sleep, you wake them up. The first symptom they're going to get is neck pain and headache. And so there's this here too, Excedrin back and body. I'm kind of joking about that. Actually, my real joke is this one here called Excedrin subarachnoid hemorrhage. That's like Excedrin stroke. It's not highly appropriate to put in there, so I'm sorry about that. They should change the logo that says the pain stops and you don't, and somehow they got to rework that. So Other treatments out there if you're not going to use over-the-counter analgesics. My point is Excedrin works well, but don't overuse it. It causes trouble. Alternative therapies. Yeah, there's a few things out there that can be done. We talked about this before yesterday, some vitamin therapies. I'm a huge magnesium believer. You can tell that someone's been to my clinic because I've jammed them full of magnesium. It's what we do. Someone asked questions about craniosacral therapy or other types of physical therapy without starting an arm wrestling match with other people in the panel. I do think that's effective for some people. I certainly don't want our folks who've got neck anatomy anomalies to have high velocity maneuvers to the neck. That means no cracking procedures to the neck, please. However, soft tissue work to the neck by a trained clinician I think is quite safe and for some people quite effective. Who's heard of craniosacral therapy here in the audience? Okay, now I'm going to really start a fist fight. Who thinks it's effective? Oh, good. All right. So it doesn't work for everyone, but I got to tell you, I got nothing that works for everyone, right? And some people do well. So if it does no harm and can be effective, I'm all for it, especially if there's no side effects. So I'm all about that. Acupuncture, chiropractic is the same thing. Remember, chiropractic I think is reasonable, however, no high velocity maneuvers. If your chiropractor says that it's all I can do is crack your neck, I prefer our folks not to do that. That's also a lot of controversy there too. So we talked a bit about cervical facet pain, and there's a few things about this. So someone asked a question about radiofrequency ablations yesterday. I wanted to throw in some slides for that too. Here's a picture of normal neck structure, and this is the bones of the neck. I don't want to gross anyone out too much. It's not even lunchtime yet. But here you got the bones of the neck and some joints right there, and then you've got severe arthritis in this lower picture. And one of my frustrations is that when you talk about someone's neck MRI, radiologists are far more concerned about discs than they are the facets. Discs are the things that support the neck and help you when you're trying to cushion the bones in between. The facet joints that we talked a bit about yesterday, those are the side joints that click and pop. Those ones usually don't have any issues to the spinal cord. So if someone has horrible facet problems, their spinal cord's fine, they're not going to get paralyzed, they're not going to die from it. And radiologists focus on the discs, the front portion of the neck, much more than they do the side joints or facets. But I'm going to give you an example. I'm going to put on here what they call a sagittal MRI of the cervical spine. And you don't have to be Dr. Buparaj to understand these pictures. Let me put a little arrow right here on this. Okay, these are the side joints of the neck. Again, not the facets, the side joints of the neck. And what I'm showing here are signs of arthritis. So see this bump right here and this is between the C2 and the C3 facet joint. And that's all inflamed and irritated. So if someone's had a cervical fusion at C4-5, or if someone's had a cervical fusion upper or lower, that can actually make you overwork the higher joints and give you more risk to develop this arthritis at a younger age. People who are hypermobile are at more risk to develop irritations in these joints than other people are. And there's ways to treat this. So if you find these inflammation lumps in the cervical spine that are on the side joints of the neck, you can calm them down by numbing injections so that every one of those nerve roots or the facets on the side of the neck have small nerves that go to them that provide pain sensation to that joint itself and not a whole lot else besides that. And a skilled practitioner can take a small pin under an x-ray machine and numb those joints. And if it works well with short-term numbing medicine, then you get into something called a radiofrequency ablation. And in a radiofrequency ablation, or if you're cool, you call it an RFA, is where you put the probe in, but instead of injecting numbing medicine, you heat up the nerve and make it stop working. And when you make it stop working for 6 months to 2 years, you can dramatically improve some people's headache. So we certainly do that in our clinic, and most clinics that do advanced headache work are able to offer that for folks. Here's what it looks like under the x-ray. This is just an x-ray of someone's neck. Here's the front of the spine with the discs like we've talked about before. Here are those side facet joints. And this is showing a clinician's injection pin in the right spot, trying to numb the nerve that goes to that spot. And that's what it looks like under the x-ray machine. Quite effective for some people. And the last thing I want to talk about is this idea of centralized pain. So who here in the room's heard of fibromyalgia? Anybody? Good. It's amazing. If you ask physicians, I'm talking about board certified, mostly physicians, and you ask them how many of them believe in fibromyalgia, not everyone's hand goes up, which is amazing to me. It's kind of like the Easter Bunny where some people believe and some people don't. But fibromyalgia is a real thing. And if you don't believe in that concept and you're a medical practitioner, come talk to me afterwards. I never lose those arm wrestling matches. But there's excellent evidence. It's actually where migraine was 25 years ago. So migraine 25 years ago was a collection of symptoms that were thought to be related to anxiety, stress, or whatever else, and really not thought to represent a neurologic syndrome. Now we know that migraine is very much neurologic. You can map it out. You can see all kinds of inflammatory markers that go along with that. And fibromyalgia is there too. It's just a couple steps behind. But if you look at fibromyalgia, that represents the same thing as migraine, an enhanced nervous system that is overactive to sensory stimuli, except instead of it focused on the head and neck, it's for the rest of the body. And these folks here have the same thing that migraine does, which is enhanced amplification of sensory information. Problem in fibromyalgia is that the body's too sensitive to signals coming up and also not able to shut off those signals once they're there. And there are treatments that can be effective for that. Who knows the most effective treatment for fibromyalgia out there? What's that? Lyrica. I'm gonna say no to that. If this was the X factor, you'd get a big X sign. But good guess. All right, that's certainly one of the most prescribed agents out there. Moist heat, not quite. So this is. Well, I'll get to that in a second. I'll come back to the slide later, maybe. All right, so this is the most effective treatment for fibromyalgia. Who knows who this guy is? Richard Simmons, right? Tell us about Richard Simmons. Richard Simmons was obese as a teenager and in his early 20s, right? He also spent 1 year at Michigan State University. Go State. And he also, and this is why I'm showing his slide here, he's actually the champion for people with fibromyalgia. And the reason why that is because his whole deal is get your body moving. Not that you've got to run laps, not that you've got to do one-arm push-ups and clap in between. Get your body moving. And we know that if you actually get someone to be physically active, if you get their bodies moving the way they're supposed to, not running laps, not doing push-ups, but actually chair exercises. Sometimes if someone's deconditioned from pain, sometimes slow walking, 5 minutes one way, 5 minutes the other way. Activating endorphins and enkephalins in the body is one of the best ways to reduce fibromyalgia, but also chronic headache. Again, not physical exercise, but here's the deal. Medicines that you may be familiar with, Vicodin, Norco, Percocet, those medications work on opioid receptors, just like things like endorphins and enkephalins do. So if you're on medications that are treating opioid-based pain, your body already says, I don't need to exercise, I don't need to do things. When you start exercising on your own, your body releases hormones in the body that work on the same spot as opioid-based pain medications do. So it's a way of repriming your nervous system. So our job for people who've got chronic headache and then body pain throughout their whole body is to find some way to get them physically exercising in a safe and effective manner. And that's really an effective way to help people with pain. One last thing, and I was seeing one of our favorite patients yesterday in clinic, and she reminded me that she has a shunt in place and that she has done well with a topical agent to her shunt tubing, and I figured it's worthwhile mentioning that. I actually had a slide for that, and I don't know what happened to it. I think that the Easter Bunny ate it or something like that. But here's the deal. There's some numbing medicines that come in a tube or a topical approach, and you can apply them to the scalp. You can rub them into the skin. So people with a shunt tubing that gets inflamed or achy sometimes, people who've had craniotomies where the surgical scar flares up and becomes painful or sensitive at times, you can rub numbing medicine like lidocaine, or you can be super fancy and make a compounded cream, meaning you go to a special pharmacy that mixes up stuff right there for you, and you can put in not only lidocaine, but medicines like ketoprofen, medicines like gabapentin, which is Neurontin, medicines like amitriptyline, which is a pain medicine, into a goop that you rub onto your skin, and that can penetrate through the skin and make those sensitive pain fibers in the scalp calm down or be less irritable, less agitated. The great thing about that is there's no side effects. So if it works, awesome, hell yeah, high fives for everybody. If it doesn't, you haven't lost anything. You know, there's no one has yet to take a swing at me in clinic because I put them on a topical gel that didn't work. So with that being said, just a few things to conclude. If someone has intracranial hypertension, and think about the signs of that, so headache, visual changes that come with headache, pulse synchronous tinnitus, those kinds of things. This is a long journey. I'm showing this picture to represent a long journey people have with their symptoms and chronic headache. This guy is swimming. Yes, he's got just a little Speedo on, and yes, he's under ice. And yes, if you haven't guessed it, he's Scandinavian. Treatments exist for those with headache. So I get really concerned when someone's had 5-10 years of headache and have given up with treatments because we've got new cool stuff that can be really effective for people. And it's really disheartening when someone says, I just kind of gave up and I've been incapacitated from chronic headache. I've stopped looking for things. We do have things that can be really effective. The next thing is consider centralized pain. Centralized pain is a real phenomenon. In people who've got daily headache, you can activate or bring out centralized pain in people so that your body becomes overly sensitive over time. And there's ways to help that too. I showed the physical exercise slide because that's the easiest thing to do, and us physicians forget about that frequently. But there are excellent treatments out there too. You mentioned Lyrica, pregabalin. There's also other medications that can be effective. There's dietary things that can be effective. There's physical reconditioning outside of exercise that can be effective for that. So if you do all that, maybe your journey doesn't have to end with frustration. This guy's going to break the Guinness Book of World Record for underwater ice swimming. That's why I'm showing this one. Check that out. He held his breath for 1 minute, 26 seconds, and he comes up for air. So thank you very much for your time today. I appreciate it. Oh, skydiving guy. Okay, good. I'm real sorry. That's probably the most important thing I have to cover today. So if you're addicted to YouTube like I am, and I am in therapy for it, it's getting better. So they tell me. But here's the deal. The guy jumps out of the airplane with no parachute and no shirt, right? And he's going down, and honestly, he's going to die if something doesn't happen. You don't live from this, right? So what's the crazy thing every day? What they don't show, and what I clipped my video so you didn't see it either, is that he has another partner who jumps out of the plane with the parachute, and he matches in it. They link arms halfway down, and then without going crazy, because I would be freaking out by then, right? I would be done. But they actually just latch the guy onto the other guy, and then they hit the parachute, and he survives. But this guy free falls, without a parachute, without a shirt, for a long time, and then just trusts that his buddy. Yeah, I know. Here's that trust. Trust that his buddy's going to save him and get him. So that's what happened in that video. And certainly you could find that online if you're going to look for it. Thank you very much.